Hello, Dr. A here. Welcome to your lesson on enzymes. This is on Chapter 8 of Larson's Clinical Chemistry. We're going to start with a question I want you to consider. So, a 57-year-old man is admitted to the ER with complaints of acute onset of intense abdominal pain. On physical examination, pain appears to be localized to the upper abdomen near the epigastric area. So, it'd be like, above the belly button, kind of below the ribs, and it radiates to the back. While being examined, the patient experiences nausea and vomiting, and the patient denies any recent alcohol consumption and states that he has not been feeling well during the past few days. What diagnosis should you consider for this patient, and what lab tests would help? So, on some of this, I know you guys are just now, learning all of this, and what I want you to consider is the location of the pain, so epigastric, and what all could be there, and then how would you test for it? Sometimes imaging obviously would be a good answer, a CT scan, often done for abdominal pain. And just so think of what kind of organs are located in this epigastric area, and then what could be causing the symptoms that this patient's having. And so there's really going to be a variety of answers, and I want you to just put something there that you think would be plausible. And part of that is to emphasize that, this exercise to emphasize that really unless you test, it's hard to know what's going on, especially with abdominal pain. And some of these enzyme tests can help to figure out what's going on with abdominal pain. All right, so let's start our introduction to enzymes. Okay, so enzymes first are biological catalysts, meaning they facilitate chemical reactions, but they are neither consumed nor permanently altered during that chemical reactions. I like to think of them as assembly lines. So you can kind of see the picture in the background there of old-timey assembly line factory work. Basically enzymes are like little mini assembly lines, and they have usually one specific reaction that they work on. They work on one substrate and create one product. And that's all they do, but they just do it over and over and over and over, as long as there's substrate present and product to be made. Enzyme concentrations are helpful, like in our case, which I know I did not give you any specific results or anything like that, is that you would order lab work, and in the lab work would be some of the enzymes, and if those come back, the different enzymes come back elevated, then that means there has been cellular injury or injury to that tissue of that organ, and you can pinpoint where the problem is. And so that's the value in testing for enzymes, is it really can help you pinpoint where the disease is or what tissue are being damaged in the process. So this little video I'm going to play here.
Enzymes enable molecules called substrates to undergo a chemical change to form new substances called products.
An enzyme.
Each enzyme acts on a specific molecule or set of molecules called substrates. Each substrate fits into an area of the enzyme called the active site. This fitting together is often compared to a lock and key mechanism. However, the enzyme changes shape a little to fit with the substrate. In the enzyme-substrate complex, the enzyme holds the substrate or substrates in a position where a reaction can occur easily. After reaction, the enzyme releases the products and can go on to carry out the same reaction again and again.
In the video that it can work the other way also. You could have one molecule that is broken down into two molecules, and that would be one substrate that makes two products instead of two substrates that make one product. But anyway, that is just an illustration of what enzymes do. A little bit on enzyme structures and properties. Enzymes are proteins, therefore they have a primary, secondary, tertiary, and sometimes quaternary structure. And the primary structure, as in all proteins, is a sequence of amino acids. As the amino acids are assembled, they start having that secondary structure that are these alpha helixes and beta pleated sheets and then random coils. And as those are made, then the enzyme starts getting a three-dimensional or tertiary structure. So they usually are globular. They have a 3D shape with an active site. We're going to talk about where the reaction happens. A quaternary structure would be if then this protein, this enzyme, has something else added into. So these can often be in the enzymatic world like cofactors and coenzymes. We're going to talk a little bit about that. But if it needs to have something added to it for it to work, then that would be its quaternary structure. Enzymes, usually as a general rule, you will find that their names end in "ase," and they tend to be named after what it is they do. And we're going to see that as we study several of the enzymes that are relevant to human health. All right, so list me an enzyme. If you're just simply on YouTube, just think about an enzyme. All right, and we're going to talk about enzyme activity. So enzymes are very efficient because they work as assembly lines, so they do the same reaction over and over and over and over again. And so you just need a little bit in the cell to produce a lot of product. The substrate is what is used to create a product. Again, so it could be, just like I said, it could be two molecules that are brought together to make a bigger molecule, or it could be a big molecule that's broken down to make two smaller molecules. The active site is where the substrates bind, and it's a non-covalent bond, meaning it's not a permanent bond. It kind of sticks on it like Post-it sticky notes, and just sticks by non-covalent bonds, and then the reaction happens, and then it lets go. When the enzyme binds the substrate, it makes what we call the enzyme substrate complex, and then the reaction happens. The allosteric site is a binding site that's away from the active site, somewhere else on the protein. And there's regulator molecules can bind in those allosteric sites. What happens is the regulator molecule, which sometimes can be the product, binds on the allosteric side of the enzyme, and then that causes the enzyme to change shape and the active site to be hidden, so that basically it turns off the enzyme because there's plenty of product there and you don't need to make any more. Enzymes can be found all over in your body, but cellularly they are, you find them in cytoplasm, you can also find them in the mitochondria, you can find them in the nucleus. There are just enzymes everywhere. And then some enzymes are found in higher concentration in certain tissues than others. That is what allows you then to identify what tissue might be releasing that enzyme. Let's talk a little bit about reaction rates of chemical reactions. So enzyme kinetics have to do with the rate of the chemical reaction, and that rate can change over the course of the reaction. So basically, how fast are they making the product from the substrate? The product formation itself is going to be affected by enzyme concentration, meaning the more enzyme you have, the faster the product is going to be made. Just like if you were in a factory, depending if you had one assembly line or two or three or four, the more assembly lines you have, the more product you make and the faster it's made. The product formation is proportional to the enzyme concentration as long as there's substrate excess. So as long as you have basically supplies going in through your assembly line, then you can keep making product. So with plenty of substrate availability, then the more enzymes are present, the faster the reaction happens. Things that can affect the reaction rate of enzymes is a pH. Some enzymes are meant to work at a neutral pH, some can work at an acidic pH, some can work at a basic pH or alkaline pH. And they usually have a certain range in which they're operational, but if you move too much outside of their range, then it can cause denaturation of the protein. It can cause them to not work. It can also cause them to not work as fast or as well as they normally would. Temperature affects enzyme reaction rates. Generally speaking, the colder temperatures will make enzyme reactions go slower, and warmer temperatures will make them go faster. unless you have it where it's too warm, too hot, and then it just cooks the protein, it cooks the enzyme, denatures, and then it doesn't work at all. Cofactors, if they are needed, their presence will affect how fast the reaction happens, or how well the reaction happens. For example, a lot of enzymes need molecules such as the metals like magnesium or zinc or selenium or something like that. And if there's not enough magnesium to bind into the enzymes to allow the chemical reaction to happen, then it's just going to happen slower. Is limited by the presence of the magnesium. And then the presence of inhibitors. Sometimes the product is an inhibitor, so once you've made so much product, it inhibits the formation of more product. But inhibitors can be drugs and other things that are basically act like kind of keys to turn off the enzymatic reaction. And so when you assess enzyme activity, you have to do it in the linear phase, in the phase that's predictable, and that is whether linear or straight linear relationships can be predicted. We're going to look at what that looks like on a graph. And so this is a typical graph of an enzyme reaction, and it does show that there's a difference in the speed of the reaction. So this is the absorbance concentration at 340 usually is of the product that you're making, and here's the time in minutes. And so you see the lag phase is like it takes a little bit to get going, and then once it's past the lag phase, it's going to speed up, and the more time is elapsed, the more product is made. And this is where measurement is taken. And sometimes measurements can be taken after a fixed set amount of time. So we could take a measurement, for example, here at 4 minutes, or sometimes it's taken at time intervals. It might be taken at 1, 2, 3, 4, 5 minutes, and then the rate of change between these measurements is used to calculate the enzyme activity. And then you reach a phase here where you're running out of substrate, and then that causes your reaction rate then to slow down. You have less product that's being made, and then you'll level off. So this linear phase here, that relationship is predictable, and measurement happens in this phase. Also, this shows reaction rate curves with 3 different amounts of enzyme. 1 has a low enzyme activity right here, then 2 has a little bit more, and 3 has the highest. And so basically, an increase in enzyme activity results in a shorter, decreased lag phase. So if you look at 1, the lowest amount, the lag phase looks like it's 1.5 minutes. But if you look at 3, which has the highest enzyme concentration, its lag phase is only 30 seconds. So it gets out of lag phase faster. And then it has a decreased linear phase, so that means it's going so fast that it burns through the substrate a lot faster. So if you look at the length of this line, the linear phase here is shorter in 3 than it is in 2 or 1, and you don't even have the other end of it in 1. And of course, the faster the enzyme works, the quicker you will reach that plateau of substrate depletion. And so if you measured enzyme activity and you did a rate measurement where you are measuring it at increments, you could see there would be differences in concentration over time between these 3 different concentrations, and then you can use that rate change to predict the concentration of that specific enzyme. All right, a little bit on the thermodynamics of enzyme reactions. So the transition state is the energy barrier that needs to be overcome for the reaction to happen. And the activation energy is the energy that needs to be supplied for that energy barrier to be overcome. And it's often supplied in the form of enzymes that use ATP to do the work. And they help lower that activation energy that is required for that chemical reaction to happen. Usually it's a 2-step reaction in which you have the first part is a substrate binding, so the substrate has to bind onto the enzyme. And then once you have your enzyme substrate complex, you have the enzymatic catalytic step where the product is made, and then the enzyme releases the product. So that's the second step. The Michaelis-Menten model is a prediction model that's based on the concentration of enzyme and substrate. And in that model, it says V0 is the initial velocity. So This is where the product concentration is 0. We haven't made anything yet. And V0 equals Vmax, which is the maximum velocity in times the substrate concentration here, divided by Km, which is a constant that is characteristic for that enzyme, plus the substrate concentration. Okay, and we're going to look on the graph here what this looks like. And in this model, you have an increased reaction rate until the substrate binding sites are all depleted. So basically, once all the enzymes are bound up with substrate, then the reaction rate cannot go any faster. It's just, again, thinking of little enzymes as assembly line. If you're bringing substrate, you're doing product to, substrate to be made into product, you bring your substrate to the first assembly line and get it going, then the second and third and fourth and fifth. And once they're all loaded up with substrate, they can't, no matter how much substrate you add, if all the assembly lines or enzymes are full and working, you can't make them go any faster. And then you can eventually run out of substrate. And so in this model, it shows here, so you have your half Vmax and your Km indicated here, but what it says is this is substrate concentration and this is speed. Okay, so again, substrate concentration S is V equals Vmax the times the substrate divided by Km of plus the substrate. In this relationship, you have first order kinetics and then zero order kinetics. In first order kinetics, the rate of your production of the product, of how fast the enzyme works, is dependent on the concentration of the substrate, meaning the more substrate you have, so we have increments here, the more substrate you have, the faster the reaction happens. So it's the substrate versus velocity. So go up, up, up in concentration, you go up in speed. And so you have a line, something that's linear, and it goes up kind of at a 45, or of course, again, this one, the angle is going to depend on the amount of enzyme present. And then you reach a point, again, where all the enzyme binding sites are saturated, and you get into zero order kinetics, where it does not matter how much more substrate you add, you are not going faster. You've reached Vmax. It is not going to go faster. And in this area, the rate does not depend on the concentration of the substrate. So a lot of enzymatic reactions can be measured in zero order here, where within the reagent you have an excess of substrate, so plenty of product can be made, and so you're taking substrate concentration basically out of the equation, and then you can calculate the how fast Vmax, the velocity here, which is going to be then proportional to the enzyme concentration. All right, so if you have an abundance of substrate and all enzymatic active sites are saturated, are you in zero order kinetics or first order kinetics? So abundance of substrate and all enzymatic active sites are saturated. All right, let's talk a little bit about enzyme inhibition. How can you turn off enzymes, or what can turn off enzymes that you might not want them to turn off enzyme during your chemical reaction? Hang on just a second. All right, so the first inhibitor is, or type of enzyme inhibition, is competitive inhibition. So the competitor then will bind to the active site where normally the substrate would bind, and then block the substrate from binding. This type of inhibition is usually reversible, meaning that if the enzyme or some of the chemical concentrations cause simply the competitor to just unbind them from that active site, then the enzyme is free to resume binding substrate and making product. There is non-competitive, and that was binding to the allosteric site we were talking about. So the competitor binds to a site away from the active site, the allosteric site, and this type of binding is irreversible. So once it binds on that, it changes the conformation of that active site where that enzyme is inactivated. And then uncompetitive is where it binds to the enzyme substrate complex. So it allows the substrate to bind to the active site, but then it caps it, if you will, and locks it in place to where the chemical reaction can't happen and the product cannot be released off of the enzyme. All right, this video is going to show that also. So it's showing first a normal
During the normal enzyme catalytic cycle, so you see the blue shape here is the enzyme, the green is the substrate,
the active site fits that substrate, so it binds, and this one you have
the enzyme then facilitates the breakdown of the substrate to its products, which part from the enzyme, leaving the active site free to catalyze another substrate as the cycle begins again.
That's your typical normal enzyme action. All right, your competitive enzyme inhibition then
competitive
is
inhibition
where
occurs when an enzyme encounters a blocker, which mimics the properties of the substrate and binds to the enzyme's active site.
And it's binding on that
Thus, when
active
the
site,
substrate is encountered, the active site is not available for attachment and no reaction will occur.
Again, that one is reversible. And then you have your non-competitive enzyme inhibition, where
non-competitive enzyme inhibition involves the binding of a blocker to the enzyme away from the active site. This binding causes a conformational change in the enzyme, altering the shape of the active site, which prevents the substrate from binding. No reaction will occur as long as the non-competitive blocker is bound to the
it's been
enzyme.
hidden, and you have no reaction. And that's it, and it doesn't have the uncompetitive, but you get the idea. All right, talk a little bit about activators, coenzymes, and prosthetic groups. So activators are molecules that bind and increase the activity of the enzyme. These are often cofactors such as magnesium and calcium, zinc, selenium, etc. to make all of the enzymatic processes in our body that require those happen faster and smoother and better. Coenzymes are organic substances that are loosely bound, and they also help the reaction. For example, NAD. So the difference between a cofactor and a coenzyme is a cofactor is often like a metal type molecule, whereas a coenzyme is another organic molecule. And prosthetic groups are tightly bound molecules that are part of an enzyme, and they could be a coenzyme or an activator or another molecule. All right. A little bit again on enzyme reaction conditions. So pH and temperature, as we talked about a while back, is important. Enzymes have an optimal pH and temperature at which they react. A lot of the enzymes that are relevant to body chemistry will operate ideally at normal body temperature, which is 37 degrees Celsius. And so a lot of those chemical reactions are done at that temperature. And if your incubation chamber is off from 37, if it's a little bit hotter than 37, those enzymatic reactions will run a little faster, and you may get some falsely elevated results. If it's a little too cold, those enzymatic reactions will run slower, and you may get some falsely decreased results. And you measure enzyme concentration in zero order kinetics, but you would substrate concentration would be measured in first order kinetics. And again, refer back a little earlier on the Michaelis-Menten model to understand that. Presence of activators, or the activators are needed, are they there? Of course, if it's in a reagent, those should be provided part of the reagent. And the presence of inhibitors, that can sometimes, there might be some inhibitors present in the serum of the patient that may interfere with the enzymatic reactions. But ideally, if this is part of a reagent, then the inhibitors would not be present, and they would be left out. But you do need to also think of that as part of body chemistry. You have to make sure you have all your activators, they have enough magnesium, enough calcium, enough zinc, enough selenium, and all these others, B12, B6, all the vitamins, and that the inhibitors aren't present. So sometimes drugs can be inhibitors. Isoenzymes are enzymes that catalyze the same reaction, but they have slightly different structural and biochemical properties. And so they do the same job, they just look slightly different. And so since there are variations in how they look, we term them isoenzymes, and sometimes there are instances where the isoenzyme that's present makes a difference. The most commonly measured isoenzyme is CKMB, but even at that, it's not used as much anymore because it's basically been largely replaced by the troponin. Laboratory techniques to measure different isoenzymes usually include electrophoresis or various immunoassays. Enzyme measurements are generally performed on serum, plasma, and body fluids. Enzymes are present in very low concentrations in those fluids. There are two different types of assays. There's endpoint assays and kinetic assays. Endpoint assays are performed over a fixed time period, and then the amount of product is measured, meaning the more enzyme you have, the more product would be made, and this is with abundance of substrate. With kinetic assays, the reaction is monitored continuously over time. Most enzymatic assays are kinetic assays, and those need to be read in zero order. So you can go back and see that where in the part where that relationship is linear on that curve. So it goes like this and then it goes like that. So zero order is when it's flat, but it needs to be predictable. And so this is where it's going to be read continuously over time, take rate. So they're rate assays. Kinetic assays are rate assays. And we measure at a certain time frame while you have substrate, plenty of substrate availability and substrate saturation on the enzymes. The unit of measurement of enzymes is international units per liter. It is a measure of activity. It represents the amount of enzyme that is required to convert 1 micromole of the substrate into a product in 1 minute. Here's a short activity if you're on my Nearpod activity. All right, so let's get into some specific enzymes. We're going to start with the aminotransferases. There are two of them, AST and ALT. They catalyze the transfer of amino groups from amino acids to form 2 oxoacids. And so that is why they're aminotransferase. They transfer amino acids, aminotransferase. So AST makes L-glutamate and oxaloacetate, and ALT makes L-glutamate and pyruvate. And the clinical significance, both are found in all major organs, but AST is primarily found in the heart, liver, skeletal muscle, and kidney. So heart, liver, skeletal muscle, and kidney. Those are the richest, if you will, in AST. And you usually find it in the cellular cytoplasm and in the mitochondria in those locations. ALT is found in the cytoplasm only. It is not a mitochondrial enzyme. And it is primarily seen in the liver and in the kidney. And so this, knowing where you normally would find it, can help you figure out what's going on when you have AST and ALT are often ordered together. They are part of a comprehensive metabolic panel. They are part of a liver function test. And then you can use the results to interpret. So, for example, being both present in the liver, then if you have liver injury, then you would expect that both AST and ALT would be elevated. But if you had a heart injury, you would expect AST to be elevated because it's present in the heart, but ALT to be normal. So again, to keep that in mind. So again, AST and ALT are part of that comprehensive metabolic panel and also part of the liver function test. And AST and ALT are measured when you evaluate a patient for liver disease. That's really its primary function because they're expected to be elevated in liver diseases. They reflect hepatocellular destruction, such as this causative viral hepatitis. That's because there are intracellular enzymes, so they're inside the cell, and they're mostly, again, largely present in the liver. And so if your liver cells or your hepatocytes are being destroyed by a disease process such as the viral hepatitis, those little hepatitis viruses are causing the hepatocytes to burst, right, as they release the viruses. But as they release the viruses, they're also releasing all the enzymes that are contained in the cell, and those are detectable then in the blood because the enzymes have to go somewhere, so they're going to end up in the bloodstream. So you will also often see elevated enzyme levels before the patient even has symptoms. And elevations of AST and ALT can be seen in as much as 100 times the reference range, meaning when there's viral hepatitis going on, these can go really high. So they can go into the thousands of international units per liter. ALT does have a greater specificity for liver disease than does AST. As we saw, ALT is mainly present in liver and some in the kidneys, whereas AST is in a lot of other places. So we generally do them together. If the ALT is elevated, you can pretty much bank that you're having an issue in the liver, unless you know this is a known maybe renal patient. The lab procedures for your aminotransferases, so they are measured using a couple of different reactions that are coupled to a specific dehydrogenase reaction. Ultimately, they measure the conversion of NAD to NADH at 340 nanometers. And as you saw, I kind of color-coded it. NAD is colorless, NADH is yellow, and you used a kind of violet, purpley wavelength to measure yellow because they're opposites on the color spectrum. Hemolysis generally should be avoided when measuring AST or ALT because both are present in large quantities in your cellular cytoplasm. At this point in time, I don't need you to memorize what these reactions are. We're going to go over them in the lab. You can also I have a more detailed video on these where you can find that information. Yeah, I want you to think about this application for just a split second. If the AST is slightly elevated, so it's above normal, but the ALT is normal, what would you suspect? Would you suspect a slight liver injury or infection, a muscle injury, or hemolysis? Think on that one for a minute, and if you need to rewind and go back, the answer is in what we just talked about. AST is elevated, but ALT is normal. Which one of these would it be? Next, we have alkaline phosphatase, or also known as ALP. It is a hydrolase that releases inorganic phosphate from its substrates. It is found on the membranes and the cell surfaces of the small intestines, kidneys, liver, bone, and placenta. It is part of a comprehensive metabolic panel also, and it is part of a liver function test. You'll see increases in alkaline phosphatase activity if you have an obstructive hepatobiliary disease or an osteoblast-mediated disease. So hepatobiliary, hepatoliver, biliary bile, the bile duct tract in the liver, if it gets blocked by tumors or by gallstones and the bile cannot flow out of the liver, that would be a hepatobiliary disease, then, and it's obstructive, something is obstructing the flow of bile through the liver and into the gallbladder, then that will cause an increase in alkaline phosphatase. And then the osteoblasts are the cells that help build up bones. And so we'd be thinking more of some of the bone cancers would cause an increase in alkaline phosphatase, but also totally normal in like growing children or babies or teenagers, anybody that's still actively growing, because it's part of bones will produce increased amount of alkaline phosphatase as they're growing. You would expect them to have higher alkaline phosphatase levels, especially if they're going through a growth spurt. All right, so clinical significance, again, the reference ranges for infants and children are going to be higher than the adults because of the elevated activity that's expected during the growth periods of infants and children. And pregnancy will also elevate alkaline phosphatase, and that would be because mama's building a baby, and their mama's building bones in that baby. And so, plus the placenta has elevated alkaline phosphatase. So all of that combined together, in pregnancy, you need to expect higher alkaline phosphatase levels. You do need to avoid hemolysis for your lab procedure. And there is also a heat inactivation procedure that can help you distinguish alkaline phosphatase activity from the liver and the bone. So because you would want to know if the problem, even if it's in a growing teenager, are they having gallbladder issues or are they just growing? What's going on? and or to have problems with their bone, where maybe they have a bone cancer. And alkaline phosphatase from the liver will remain after heating the sample, whereas alkaline phosphatase from the bone will be destroyed by heat. So that's one way you can distinguish alkaline phosphatase origin. And moving on, we're going to talk about gamma-glutamyl transferase, or GGT. The exact function of GGT is unknown. We do know, from what I've gathered, some of the stuff we know is it's involved in detoxification processes. It does catalyze the transfer of a gamma-glutamyl from a peptide. It is found on the cell surface and in the cytoplasm, and it's primarily in the liver. So this is a liver enzyme. The increased GGT levels are seen in a majority of liver disorders, so with unusually high levels seen in patients that have primary and metastatic hepatocellular carcinoma. And one of the ways you can use GGT is if your alkaline phosphatase is elevated in your patient and you wonder if it's liver or bone, you have that either one could be a possibility. Well, if you run a GGT then, if there's a liver issue going on, will often be increased also. But if the source of the alkaline phosphatase was bone and you ran a GGT, the GGT should be normal. So its main clinical significance is that patients with alcoholic cirrhosis or chronic alcoholics will display elevated GGT activity. So again, it's related to consumption of alcohol, because I believe it's part of the detoxification process. The more alcohol you consume, the higher your GGT levels. These are often used in rehab clinics to check adherence to protocols and to see if somebody, if they claim to be clean and sober and all of that they actually are. At least we can check if they are, if they have been drinking or not. So that can help detect alcoholism or relapse in alcoholism in rehab therapy. So again, GGT is often measured when alkaline phosphatase activity is elevated, and you will want to distinguish between the alkaline phosphatase of hepatic origin versus that of bone. So if alkaline phosphatase and GGT are both elevated, then it's the liver, it's hepatic. If alkaline phosphatase came from the bone and it's high but the GGT is normal, then it means that it's the bones that are producing the alkaline phosphatase, and then you're not having any kind of liver issues. Hemolysis does not affect your GGT levels. It's not contained in red cells. Okay, so do this little matchup activity, and then we're going to go over a few questions. So if a pregnant patient had signs and symptoms of gallstones, so think about she's pregnant, she would have alkaline phosphatase that's elevated because of the placenta and the growing baby. So then which test would you order to confirm the source, liver or pancreas, or placenta, actually, not pancreas, or placenta, of the elevated alkaline phosphatase? I'm going to go back and change that. So would you do AST and ALT or GGT? So you want to know if it's just normal alkaline phosphatase elevation of her making a baby and having the placenta and all of that present, or is it alkaline phosphatase is elevated due to some other liver issue going on, possibly a gallstone? If your patient has a biliary obstruction or a gallstone, what would you expect? So this is what result pattern would you expect? And so the choices are going to be high alkaline phosphatase, normal GGT, low alkaline phosphatase, high GGT, high alkaline phosphatase, high GGT, and low alkaline phosphatase and low GGT. So what do you think pattern would fit in biliary obstruction based on what you've learned so far? Next question is going to be, if your patient is a child with growing pains, what would you expect? Again, same kind of patterns. Pick which one you would expect for a child with growing pains. Your next enzyme is going to be creatine kinase, or CK. CK catalyzes the reversible phosphorylation of creatine to creatine phosphate by ATP. Basically, This little nifty little enzyme helps you store ATP, the energy, as creatine phosphate in your muscles. So then when you use your muscles and you exercise, then you have you can make the ATP. So you have to put the creatine phosphate back into ATP and use it to power your muscles during exercise. The forward reaction will occur in the mitochondria. So that's the ATP to ADP with the production of creatine phosphate. That's where that phosphate is going, and that energy gets stored in the muscle in the form of creatine phosphate. The reverse reaction will occur in the cytoplasm, where ADP is made back into ATP, and this production of energy then is necessary for your muscular contractions. The isoforms of creatine kinase are usually subunits M and B, so you have CKMM, CKMB, and CKBB. If you draw blood and analyze it, 98% of the CK in the blood is going to be of CKMM origin. Just this is in normal blood, everything's fine. And then the other 2% is going to be spread between the CKMB and the CKBB. Again, the CKMB of all the isoenzymes or isoforms is the one that still is used in the in the context of cardiac assessment, because CKMB is specific to the heart, CKBB is specific to the brain, and CKMM is specific to the muscle. Probably should have specified here the subunits M is for muscle and B is for brain. And so basically you can think of your heart as a muscle with a brain, because it's self-pacing and it knows what it's doing. The clinical significance of CK. Total CK elevations are usually seen after any kind of muscle injury or trauma, because the majority of the CK is inside the muscles. Muscular diseases such as muscular dystrophy and rhabdomyolysis will show extreme elevations, and so these are elevations that are in the tens of thousands, extremely high. An acute myocardial infarction will also increase your total CK, because it is the heart as a muscle. Therefore, the heart has CK. If you have a heart attack or a myocardial infarction, it's going to damage the heart, and therefore it's going to cause damaged heart muscle to release the CK that was contained within. The lab procedures for CK is usually measured by a couple reaction, with the final step being the oxidation of NADP to NADPH with a color change that can be measured. And then CKMB is usually done as an immunoassay, again in the context of heart attacks. The next one is lactate dehydrogenase. The physiology is that it catalyzes the reversible oxidation of lactate to pyruvate. Where do we know lactate and pyruvate from? Pyruvate is what enters your Krebs cycle, your citric acid cycle, to make ATP in your mitochondria. If you don't have enough oxygen present, that pyruvate can be shuffled and made into lactate, which is basically lactic acid. Makes your muscles sore and all that. But then later on, the liver can start turning all that lactate into lactic acid back into pyruvate, which then can go back and be made into energy. The lactate dehydrogenase activity exists in all cells, because all cells have to produce energy, and concentrations are higher in the cytoplasm of those cells than in serum. You see significant activity if you have heart, liver, heart disease or heart damage, liver damage, red blood cell damage, kidney damage, or skeletal muscle damage. So anything that damages those would release lactate dehydrogenase and cause a spike in your serum. So it's very non-specific, because it's found everywhere. It does have isoenzymes, M and H for muscle and heart. We don't hardly measure lactate dehydrogenase isoenzymes. There's just not that much value to it anymore. Elevations can be seen in such a variety of disorders. Sometimes they're done, but they're not very specific. If you can do a level and then you do treatment and the levels go down, it would just mean that the treatment you're doing is working. But it can be, again, it's not very specific for a test. So you can see significant elevations in pernicious anemia, megaloblastic anemia, and some cancers. The lab method is the LD activity is measured during the forward reaction of the catalyzed reaction from lactate to pyruvate. Since LD is found in red cells, hemolyzed samples are unacceptable for analysis because you would have false elevations. Next, we have amylase. The physiology of amylase catalyzes hydrolysis of alpha glycosidic bonds in order to release various sugars from starches. So basically, amylase helps you break down your breads and pastas and cookies and cakes and things like that. It is produced from the acinar cells of the pancreas and the salivary glands. It is a digestive enzyme that is secreted in your digestive tract. The clinical significance is greatest elevation of serum amylase activity are seen in acute pancreatitis, where it's showing up in the blood instead of being dumped into your GI tract to digest your starches, because the pancreas, the acinar cells in the pancreas make the amylase and normally make it store it up and then release it. When you have acute pancreatitis, then or salivary gland inflammation, those cells that are making the amylase are damaged and therefore release the amylase, and that's how it shows up in the blood. So ideally, to diagnose acute pancreatitis, you need amylase and lipase, which we're going to talk about lipase in a minute. Amylase will peak at 12 hours after bout of acute pancreatitis and will return to normal in 3 to 4 days post-pancreatitis. The lab methods for amylase are a coupled enzyme reaction that results in the measurement of NAD plus at 340 nanometers. The testing is available to differentiate the activities of the P-amylase and S-amylase. So I keep wanting to say plasma. It's not plasma. Pancreatic. It's pancreatic. Sorry about that. Pancreatic amylase and salivary amylase. Although really, if you're having some problems with your saliva glands, they probably are going to be, swollen. Like think of mumps where, they have big swollen saliva glands, and you have elevated amylase. It's probably from that location. And then with the pancreas, you can do CT scans and see what's going on. So even though it's available, it's not usually necessary to do. And then lipase. The physiology is that it catalyzes hydrolysis of triglycerides into cholesterol and fatty acids. So it breaks down your fats so that you can absorb those fatty acids during digestion. Again, another digestive enzyme is generally produced by the pancreas, released in the digestive tract as you digest your meal. It really shouldn't be in large amounts in the blood. If it's showing up in the blood, it means, again, your pancreatic cells are being destroyed by pancreatitis. So lipase is almost exclusively of pancreatic origin. You don't have salivary lipase. You do have some intestinal lipase, though. But when we measure it in the blood, it pretty much correlates to issues with the pancreas. So during an acute pancreatitis bout, the lipase will peak at 24 hours, and then it won't return to normal until 8 to 14 days later. So it hangs around longer, which makes it then more specific for pancreatitis. Increased lipase activity is more specific than amylase activity when you diagnose acute pancreatitis. That's why ER physicians always do both. Somebody comes in with abdominal pain, they'll often do comprehensive metabolic panel, which will cover the liver with AST, ALT, and alkaline phosphatase, and they'll add to that amylase and lipase, and then you cover it with that assessment of the pancreas to rule out pancreatitis, or rule in pancreatitis. All right, so we got some questions here we're going to look at when you're on Nearpod. Hang on, I went too fast here. Question 1. Which enzymes would you suspect to be elevated in acute pancreatitis? Answer that. Which enzyme would you expect to be elevated in a heart attack? Select one of those. Which enzyme would you expect to be elevated in a gallbladder attack or gallstone? Select one. And which enzyme would you expect to be elevated in acute viral hepatitis? Select an answer. Rhabdomyolysis would elevate which one of these? And which enzyme is elevated in alcoholics? And last, which enzyme would be elevated in pregnant women? And if you're in my class, you of course have your last, do you have any questions? And hopefully it's all good. I do have some more detailed YouTube videos on the enzymes that you can check out. And other than that, have a good day.